Welcome. In this video, we'll be covering the ins and outs of a research study I was part of that was published in JMPT in 2020. Our group was able to show that ankle manipulation positively impacted hip abductor activation and strength. The idea for this study started with a clinical observation that ankle subluxations can create a TFL inhibition, and conversely, adjusting the subluxation seemed to correct the inhibition. This is something I discovered years back, and I use the word discovered loosely as I honestly don't remember how I picked this up. I did have some early exposure to applied kinesiology, but in looking back at my AK manual from the time, I don't see much of a connection between the TFL and the ankle. More than likely, it started with the way a lot of these things begin, which is observing it in one patient and then looking for it in other patients and noticing a pattern. In any case, it seemed to make sense anatomically, as the TFL at least partially attaches onto the head of the fibula via a posterior slip of the band here. In any case, I became confident enough that I approached our local university's DPT program, whose lab manager I'd happened to meet. I brought in my wife to demonstrate this effect, who fortunately had an ankle issue at the time. Of course, I had to make her wait 2 weeks to demo this before we could actually fix it. So we'll look at some studies that provide some background context to our study. Hip abductor weakness is a known phenomenon after ankle injury. There are a number of studies that show changes in the hip muscles after ankle injury, including altered glute medius activation timing. Interestingly, not the amount of activation, but the timing during the gait cycle. We'll comment more on this later. Altered prone hip extension firing patterns, glute max facilitation, so not inhibition, but the opposite, facilitation. In fact, an author speculates that there's a feed-forward mechanism going on where the body recognizes the abductor deficiency and is using glute max to compensate. It would have been interesting if we had measured glute max in our study. Unfortunately, these studies were published after we had already locked in our study design. Had we known, we could have put some electrodes on glute max and see if that had any changes. In looking through the literature for treatment studies relating to the ankle and hip muscle effects, we discovered that nobody has really looked at ankle manipulation affecting the hip. There are 2 studies showing changes in hip muscle strength following hip joint manipulation. You'll find these referenced in the muscle inhibition background video, but nobody had really looked at the ankle as of yet. There was one study showing that ankle manipulation helped the soleus muscle activate better, so a local change to ankle manipulation. It seemed logical that if ankle manipulation can help local muscles fire better, it could also help hip muscles fire better that are known to suffer after ankle injury. Although again, to be honest, I was approaching this more from a clinical observation mindset. I didn't initiate the study because this seemed like a next logical step in the literature, but it's nice to know that it corroborates what I was seeing clinically. For our study design, we kept things deliberately pretty simple. This was just looking at a proof of concept. We recruited 25 subjects, mostly DPT students, who had a past history of ankle sprain. This wasn't hard to find. This is a perfect population, actually, as they tend to be banged up with old sports injuries. There is a reason that these kids are in PT school. They had to have a unilateral hip abductor weakness as measured with a TFL muscle test. We chose TFL over glute med because I thought TFL was more sensitive to ankle joint dysfunction and less prone to lumbopelvic issues, so the glute med can be inhibited when there's a low back issue, and I thought TFL was less sensitive to this. We excluded anybody who failed a pure hip flexion muscle test. TFL incorporates a lot of flexion in its vector, so if somebody had iliopsoas weakness, that was going to confuse the matter. And obviously we also excluded anybody who had contraindications to ankle manipulation. So we did pre and post manipulation activation and force measurements. For activation, we put surface electrodes on TFL, glute med, and rectus femoris. We were most interested in TFL, so the protocol is you also capture the muscles on either side of it. And for force production, we measured using a custom design rig holding the force transducer. Each subject did repetitions of maximum voluntary contractions. This is the standard protocol to measure activation and force. So the intervention consisted of a session of high velocity, low amplitude ankle manipulation, targeting the proximal tib-fib joint, distal tib-fib, as well as the talocrural and subtalar joints. For the last three joints, I utilized kind of a different setup than the conventional one where you rely solely on arm power. I prefer this version where you utilize a hand contact but place your arms between your legs and generate the thrust more with your glutes and hamstrings. Obviously, you can generate a lot more power with this version, and I find my success rate is better. By the way, we blinded me from the data collection, so two examiners would take a pre-intervention measurement. I would enter the lab, deliver the adjustments, leave the room, and then they would collect the post measurements. Results. So we kept track of what was adjusted, and right off the bat, the first result that was different than what I was anticipating was that only about half to 3/4 of the fibular joints required a cavitation, a release, while 100% of the talocrural and subtalar joints cavitated. This was a shock to me because anatomically, as we mentioned earlier, I associated the TFL more with the fibula. I am a believer that you need a cavitation to get the best results, but it appears the joint dysfunction was most consistently present at the talus and calcaneus. As far as how the hip muscles responded, I know you're dying to know, but this was the second surprising result, to me at least, was that yes, activation increased. I was reasonably confident this would happen, otherwise I wouldn't have initiated the study. But it was which muscles that responded that were surprising. It was glute medius that had the biggest statistically significant increase. TFL, if anything, dipped a bit, but not to the level of significance. My co-author, Dr. Brian Swanson, had the thought that it was possibly the anterior fibers of the glute med that were responding. They have the same action as TFL. We'll talk about this more in the discussion section. And so activation increased, and strength tends to follow activation. So yes, hip abductor strength increased also. However, this was the third and final surprise of the study for me. The force didn't actually improve immediately, at least not to the level of significance. Going from pre-manipulation to the immediate post-manipulation measurement wasn't enough to register. It wasn't until the 48-hour measurement that it got to the level of statistical significance. It's interesting because when you do the muscle testing and the manipulation clinically in the office, you see an immediate improvement in strength, but I guess the difference is we're not testing maximum contraction in the office. They're probably registering at 50%. We have two theories for why this finding was as it was. Either the subjects were fatigued after doing multiple reps of maximum voluntary contractions, or it took a couple of days for the body to recalibrate, so to speak, or as my co-author Dr. Swanson put it, adjust to the improved arthrokinematics. By the way, it's difficult to measure activation 48 hours out. The electrodes have to be exactly the same place, so if you're wondering why we didn't measure activation at 48 hours, that's why. Discussion. So to summarize, in subjects with a past history of ankle sprain and a unilateral hip abductor weakness, one session of ankle manipulation improved both glute med activation immediately and hip abductor strength at 48 hours. In both cases, bringing it up to the level of the unaffected side. So in looking at the prevalence of hip abductor weakness after ankle injury, looking to the literature, other than our study, there are no other studies yet. However, if you extrapolate our numbers, you maybe get a sense of the scope of this problem. We screened 55 subjects to identify 25 that had hip abductor weakness. Again, these are subjects that had a previous history of ankle sprain. If anything, our population was more likely to be doing hip abductor strengthening exercises. Again, these are DPT students, so they're more likely to be doing clamshells and banded walks. So if they have a unilateral weakness, it's conspicuous. There are approximately 2 million ankle sprains in this country each year. So if you do some back of the envelope math, 45% of that 2 million equals almost 2 million potential people walking around with hip abductor weakness after sprain. That's pretty significant. I'd also like to take a minute and discuss the time factor. In doing a literature review of any and all studies that looked at a motor effect from manipulation, I identified 21 over the past 20 or so years. By the way, this is discussed in more detail in the muscle inhibition background video if you're interested. But of these 21 studies, only 5 looked for the effect to last beyond the immediate post-manipulation time period. And excluding one case study, ours was the only study to demonstrate the strength effect lasting beyond 30 minutes. I think there are 2 reasons for this. The first being many studies just didn't look for the effect to last. But also ours was one of the few studies to A, look for it, but B, identify subjects that had a weakness to begin with. So we had a deficit to correct. And in my mind, correcting a deficit and seeing a lasting improvement is perhaps more clinically meaningful than taking a muscle that's not inhibited, doing a manipulation, and seeing a quick burst of strength increase. But if that only lasts a few minutes, I'm not sure how relevant that is. So it turns out our study was the first of its kind in 2 different ways. We were the first to show a proximal effect from the ankle manipulation. When I talked to other providers, not just chiropractors, but physical therapists and sports docs, this is the finding they really key in on. Say, wow, you were able to make a change at the hip from the ankle. And as we discussed, the time factor, we were the first to show a sustained effect lasting beyond 30 minutes. I think together these 2 effects were the reason that we were able to garner an award from the JMPT, which was a nice interdisciplinary recognition. I know most people watching these videos are providers, and they're saying to themselves, just tell me why this matters. How does this apply to my patients? Well, it turns out it matters a lot. Glute muscle dysfunction is associated with a laundry list of issues, including ankle, knee, hip, and low back pain. Just one example from the literature is the finding that individuals with gluteal tendinopathy tend to exhibit altered hip abductor activation patterns. And my observation is that glute med inhibition from ankle dysfunction is a frequent contributor to these pain patterns. So if glute medius is inhibited, that could very well explain the compensation in the rest of the glutes, creating gluteal tendinopathy, IT band, ankle pain. Hip abductor muscle testing provides a quick screen to help identify the inhibition in these cases. And unless you identify the inhibition, you're not necessarily going to recognize the full scope of the problem, and you're not necessarily going to be able to fully fix it. I've treated literally dozens of athletes who have seen other quality providers who were prescribed the correct exercises in these types of cases to strengthen the hip abductors, only they didn't respond because they were inhibited. The other side of the coin of hip abductor muscle testing, the other value, is that it helps as a quick screen for ankle dysfunction. So in our offices, we use a 5-part ankle screen if we want to thoroughly evaluate an ankle, including a wall test for dorsiflexion, single-legged balance and single-legged squatting, and a strength evaluation of the intrinsic local muscles of the foot. But this takes 5 minutes to complete. If I have a patient with symptoms that sound like it could relate to hip abductor inhibition, such as lateral hip pain or lateral knee pain, I can start with hip abductor muscle testing in the TFL position, and if it's test strong, I might decide to pursue other potential underlying causes. But if they test weak, then I might go on to do the full screen, the full ankle screen, or as much of the screen as I needed to identify the problem. What could those problems be? Well, patients with hip abductor inhibition tend not only to have ankle subluxation, but also ankle mobility and or stability deficits left over from their prior injuries. So for example, reduced dorsiflexion, as you see here, poor balance, etc. And to really fully resolve this issue, you're going to have to address these soft tissue deficits as well. So how do you go about identifying and fixing these types of inhibition issues? Well, I've spent the past 20 years trying to answer that very question. In our offices, we've developed protocols to quickly and efficiently diagnose and treat muscle inhibition, particularly in the muscles that matter most. If it's not up already, I will be posting soon a video specifically covering hip abductors. Until then, thanks for listening.